You might think of the neck as just, well, the neck.
Right.
But for a surgeon, it's way more than that.
Oh, absolutely.
It's like a meticulously mapped landscape, a place where precision isn't just preferred, it's absolutely vital for safety, for function.
Couldn't agree more.
So today, we're going on a deep dive into one of the most delicate areas of the human body, the thyroid gland, and specifically the really intricate surgery surrounding it. We're going to explore, the fascinating anatomy, how the techniques have evolved, and the critical thinking that goes into every single step.
And what's truly compelling here, I think, is that we'll be exploring not just what happens in thyroid surgery, but the profound why. Why these landmarks? Why those techniques?
Right, what's the thinking behind it?
Exactly. Our mission, really, is to pull out the most important nuggets of knowledge from our sources, sort of give you a direct route to understanding the incredible level of precision needed and why it matters so much for your well-being.
Okay, let's unpack this then. Get ready for some surprising facts about the neck you probably never knew you needed to know.
Probably true.
We'll look at how surgeons use these anatomical triangles almost like a built-in GPS. We'll dive into something called the ostrich phenomenon, fascinating name in the operating room.
Yes, that one's interesting.
And understand why the capsule of a thyroid gland is apparently vastly different from a prostate capsule in surgical terms.
Big difference. Okay, where should we start?
Well, when a surgeon prepares for a thyroid procedure, they're not just looking at a neck. You're saying they visualize this hidden, complex map.
That's a great way to put it, yeah. It's a landscape that definitely demands its own navigation system. You need signposts. Anatomical signposts. Exactly. Imagine this hidden map where specific angles and triangles aren't just, terms in a textbook. They're life-saving signposts.
Okay.
And the real insight is how surgeons use these to pinpoint and, crucially, protect critical nerves and vessels.
Like which ones? Give us an example.
Okay, so take Behr's triangle. It's the specific area defined by the trachea, your windpipe, the innominate artery vein down low, and the carotid sheath laterally.
Got it.
It's basically the surgeon's entry zone, the starting point for finding the recurrent laryngeal nerve, the RLN.
And that's the voice box nerve.
That's the main one for controlling your vocal cords, yes. So finding it, protecting it, it's paramount.
So it's like a designated search area, a safety zone to start looking.
Precisely. And visual identification, actually seeing the nerve, is the gold standard whenever possible.
Makes sense. What other triangles are on this map?
Well, there's Joel's triangle, sometimes called Jober's triangle. This one's important for a different nerve, the external branch of the superior laryngeal nerve, or EBSLN.
EBSLN. Okay.
This triangle is formed by certain muscles in your throat, near the very top of the thyroid gland.
And why is this nerve important?
This one affects the pitch of your voice, especially the higher ranges. Think singing, projecting your voice.
Okay. Still very important then.
Absolutely. Protecting it is so critical that surgeons have this little saying, a golden pearl of advice. Tie close to the gland, not the cricothyroid.
What does that mean practically?
It means you secure the little blood vessels right on the thyroid surface, well away from where that delicate nerve runs, near the cricothyroid muscle. Keeps it safe.
That's incredibly precise work. You also mentioned Barry's ligament earlier. Is that another critical spot?
Barry's ligament is... It's fascinating and often tricky. Think of it as a tight band of tissue that hugs the trachea, your windpipe.
Okay.
And critically, that recurrent laryngeal nerve, the main voice nerve, often runs right within it or is intimately attached to it right there.
Wow, so the nerve is embedded in it sometimes.
It can be. This area needs really delicate dissection. There's another practical pearl here, and it's a powerful one. Never pull the nerve off Barry's ligament. Peel the gland away.
Peel the gland away from the nerve.
Exactly. It underscores that you meticulously separate the thyroid from the nerve. You don't put any tension on the nerve itself to try and pull it free. That avoids injury.
Are there others? Other landmarks?
Yeah, briefly, there's the triangle of Pirogov, which helps locate the lingual artery supplying the tongue, though that's less direct thyroid surgery, and the Zuckerkandel tubercle. Zuckerkandel tubercle. It's this little bulge, often found on the back, side part of the thyroid lobe, and it frequently points right towards the recurrent laryngeal nerve where it enters the larynx. So another handy nerve signpost.
So what does all this map talk, these triangles and ligaments mean for you, the listener? I mean, these aren't just obscure anatomical terms, right?
Not at all. They are, quite literally, the surgeon's vital safeguards. They're the system used to ensure that delicate structures, especially your vocal cord nerves, are meticulously protected during surgery. It's all about preserving your voice, your quality of life.
Okay, so we've navigated the delicate nerve pathways with these anatomical signposts. But what about the traffic, the blood flow? This area is packed, right? How do surgeons manage the rich blood supply in the thyroid without causing, well, a mess? Or worse.
Yeah, it's truly like navigating vascular superhighways in a very small space. The thyroid gland is incredibly well perfused, lots of blood flow.
So understanding the plumbing is key.
Absolutely. Arteries coming in, veins going out.
Yeah.
Take the superior thyroid artery, the STA, usually the first branch off the main external carotid artery in your neck, up around C3, C4 level.
All right.
Its path runs incredibly close to that EBSLN nerve we just talked about, the one affecting voice pitch.
Ah, the tie close to the gland nerve.
That's the one. So the key insight, again, is control its branches very close to the thyroid capsule, that outer layer of the gland itself. That protects the nerve.
So tying off vessels further away, maybe taking a shortcut, would put that nerve at higher risk.
Exactly. High risk of stretching or trapping it. Then you've got the inferior thyroid artery, the ITA.
Inferior, so coming from lower down.
Yep. Originates from the thyrocervical trunk, usually deeper in the neck, around C6, C7. Now, this artery has a notoriously variable relationship with the recurrent laryngeal nerve, the main voice nerve.
Variable how?
The nerve can cross in front of the artery, it can cross behind it, or sometimes it even weaves between the artery's branches. It's different in almost everyone.
Wow, okay. That sounds like a challenge.
It is. And a crucial pearl for handling the ITA is to try and preserve its posterior branch.
Why that specific branch?
Because that posterior branch very often supplies the parathyroid glands, those tiny vital glands sitting behind the thyroid that regulate your body's calcium.
Right, the parathyroids, tiny but critical.
Extremely critical. So surgeons also generally avoid tying off the main trunk of the ITA too far out laterally, away from the gland.
Because that might cut off blood to the parathyroids too.
Precisely. You risk devascularizing them. It's not just about stopping bleeding. It's about preserving the function of these other vital little organs.
Got it. Are there any other vessels to worry about?
Well, there's a variant, the Thyroidea artery, only present in maybe 1 to 10% of people.
So uncommon, but possible.
Right. And if it's there, it comes up right in the midline of the neck, heading to the thyroid's central part, the isthmus.
And why is that one dangerous?
It can be a significant source of bleeding, especially if you're doing a low midline incision or if a tracheostomy, that breathing tube procedure is needed. Got to be aware of it.
Okay. And the veins?
Venous drainage is a bit more straightforward, but still needs care. You have superior, middle, and inferior thyroid veins draining blood away. They all need careful management to prevent bleeding, especially the middle one, which is quite short and direct.
So tying this all together, the meticulous vessel management, it's about blood loss, yes, but also preserving those parathyroids.
Absolutely. That's the bigger picture. It's paramount.
Yeah.
It's about preventing low calcium issues post-op, which can be quite debilitating for patients. It's preserving function.
Okay, that clarifies the vessel situation. Now, I've heard the term capsular ligation thrown around. What exactly is a capsule in this thyroid context, and how has the approach to controlling these vessels changed over time?
That's an excellent question. And it really gets to the heart of a major evolution in surgical technique and thinking. The thyroid, it effectively has two capsules, if you will.
Two?
There's the true capsule. This is a very thin fibrous layer that's stuck right onto the thyroid tissue itself. It's intimately part of the gland, and it's where the gland's smallest terminal arterial branches actually penetrate.
Right on the gland surface.
Exactly. Then there's what's often called the false capsule. This isn't part of the gland. It's actually the pretracheal fascia, a layer of connective tissue that surrounds the thyroid, the trachea, and the strap muscles, those flat muscles in front of your neck.
So one is part of the gland, one is surrounding tissue.
Correct. And the core idea behind modern capsular dissection and ligation is to dissect directly on the thyroid's true capsule, and then you ligate or tie off only those tiny terminal vessel branches right there on its surface.
And why is that specific approach right on the true capsule so important now? Why the change?
It's crucial for a couple of big reasons. First, it helps preserve the blood supply to the parathyroid glands. As we said, their blood supply often comes from tiny branches off the inferior thyroid artery, right near the back of the thyroid. Working on the capsule keeps those intact.
Okay, protects the parathyroids. What else?
It also significantly reduces the risk of injuring the recurrent laryngeal nerve, especially down near Barry's ligament, where the nerve is practically glued to the gland. By staying right on the gland surface, you're less likely to stray towards the nerve.
Makes sense. So what was the old style then?
Well, in the past, the old style often involved what we call en masse pedicle ties.
En masse, like tying off big chunks.
Pretty much, tying off larger bundles of vessels, arteries, and veins together further away from the gland. Or sometimes ligating the main trunk of the inferior thyroid artery way out laterally.
A less precise, maybe faster, but more sweeping approach.
Exactly. Less meticulous. But the risks were higher. You could injure the EBSLN, the pitch nerve. You could definitely devascularize the parathyroids, leading to hypocalcemia.
More calcium problem.
Right. And ironically, sometimes even more bleeding, because smaller veins that weren't included in the big tie could retract and bleed later. Plus, more traction on the gland could put the RLN at risk.
So some modern style contrasts sharply with that.
Very much so. Modern vessel control involves meticulously identifying and controlling each small capsular branch individually, right at the gland surface.
How do they control them? Just ties?
Could be fine ties, small clips, or often now advanced energy devices that seal the vessel with heat or ultrasonic energy. Very precise. Plus, there's often heightened awareness of the EBSLN and sometimes the use of intraoperative neuromonitoring IONM to actually track nerve function during the surgery.
So technology helps too.
It can be a useful adjunct, yes. It all adds up.
This really is a great example of how medical science constantly refines its approach, isn't it? Moving from that en masse technique to precise capsular ligation that directly translates to safer surgeries and hopefully much better long-term outcomes for you, the patient.
Absolutely. Better safety, fewer complications. That's the goal.
It's incredible how that precision with the capsule minimizes complications. But sometimes the challenge goes beyond just the thyroid gland itself, right? Especially with cancer. What happens then when a more extensive neck dissection to remove lymph nodes becomes necessary?
Right. When thyroid cancer is present, and particularly if it's suspected or proven to have spread to the lymph nodes in the neck, then yes, a neck dissection becomes part of the plan.
And what does that involve? Are there different kinds?
Yes, there are different types designed to target specific areas where thyroid cancer tends to spread. The most common is a central neck dissection, or CND.
Central, so right around the thyroid.
Exactly. It typically involves removing the lymph nodes directly around the thyroid, trachea, and esophagus. These are in what surgeons call levels 6 and sometimes 7th of the neck. Prelaryngeal, pretracheal, paratracheal nodes.
Okay, and the other type?
Then there's a lateral neck dissection, or LND. This addresses the lymph nodes on the side of the neck, running along the major vein, the jugular vein. Generally, this covers levels 2 through V.
Side nodes versus central nodes. Got it. Are these always done for every type of thyroid cancer? Or is it more selective?
Oh, definitely not always. It's very nuanced. The indications vary greatly depending on the cancer's histology, its specific type when looked at under the microscope.
Okay, so different types behave differently.
Exactly. For papillary thyroid carcinoma, or PTC, which is the most common type, a CND is usually done if lymph nodes are clinically positive, meaning proven to have cancer before or during surgery.
What if they look okay?
Well, sometimes a prophylactic CND done, even if nodes aren't obviously affected, is considered for higher risk situations, like larger tumors invading outside the thyroid, or maybe in older patients, but that's a bit controversial. The benefit isn't always clear.
And the lateral dissection, LND, for papillary?
An LND for PTC is only performed if there's clear proof, usually from ultrasound and biopsy beforehand, that cancer has spread to those lateral neck nodes.
Okay. What about other types, follicular?
Follicular carcinoma, or FTC, behaves differently. It tends to spread through the bloodstream hematogenously to places like lungs and bones, rather than typically spreading to lymph nodes first.
So neck dissection is rare for follicular.
Very rare. Only if nodes are obviously involved, which doesn't happen often.
Makes sense. What about medullary? I hear that one's different.
Medullary thyroid carcinoma, MTC, is quite different, yes. It's more aggressive in spreading to lymph nodes. So for MTC, a CND, that central dissection, is considered mandatory, even for small tumors.
Wow, always for MTC.
Generally, yes, because the risk of microscopic spread is high. And an LND, the lateral dissection, is also commonly done if nodes are positive, or even prophylactically if certain blood markers like calcitonin are very high. It's just known to go to nodes early and often.
Okay. And the really aggressive one, anaplastic.
Sadly, for anaplastic carcinoma, which is extremely aggressive and often advanced at diagnosis, surgery itself is rarely the primary treatment. And neck dissection isn't typically useful in that context. The focus shifts to other therapies.
Understood. So which nodes are most commonly involved overall?
Generally, the central compartment nodes, 6 and 7, are most common. Then laterally, levels TII, 3, 4, and VEB are frequently involved if it spreads there.
And you mentioned skip metastasis. What's that?
Yeah, occasionally you see cancer cells skip over the central nodes and appear first in the lateral neck nodes. It's not the usual pattern, but it happens.
So this raises an important question, doesn't it? Why is this mapping so incredibly specific to the cancer type?
Because understanding the cancer's specific behavior, its histology, dictates the extent of the necessary surgery. It's all about targeting the disease precisely where it lives, or is highly likely to live. Not doing too much, not doing too little. It's tailored treatment, not just operating by habit.
Tailored treatment based on the biology. Okay. Now, this next concept sounds like something from a psychology textbook, but you mentioned it's real in surgery, the ostrich phenomenon. What on earth is that? And how do surgeons guard against it?
Huh. Yes, the ostrich phenomenon, or sometimes called the ostrich philosophy. It's a fascinating and very real surgical cognitive trap.
A cognitive trap, meaning it's about how surgeons think.
Exactly. It refers to the tendency, the human temptation sometimes, to avoid unpleasant but absolutely necessary checks or confirmations. Metaphorically burying your head in the sand.
Like what kind of checks?
Well, it could mean, for example, not examining the vocal cords with a scope before or after surgery when it's indicated because you're worried about what you might find. Or maybe not making the effort to definitively identify a nerve because it's difficult.
Or ignoring something that looks wrong.
Right. Ignoring a parathyroid gland that looks dusky or unhealthy, hoping it'll be okay. Or maybe not thoroughly exploring a compartment like the central neck where you suspect there might still be disease because it's easier not to.
So it's about shying away from potential bad news or difficult tasks rather than confronting them head on. How do surgeons fight that instinct? Because it sounds like a very human thing to do.
It is very human. The antidotes are really ingrained in surgical training and culture, often through these hard-won consultant aphorisms or sayings that reinforce constant vigilance.
Like the pearls you mentioned earlier.
Exactly like those. For instance, a nerve seen is a nerve saved. That constantly reminds surgeons that direct visual identification is the goal. Don't guess. Look.
Okay. What else?
Another key practice is documenting things. Always document pre- and post-operative laryngoscopy, the vocal cord check, when it's indicated. It forces the check and records the finding.
Accountability through documentation.
Yep. And if a suspected parathyroid looks like its blood supply is compromised, the instruction is clear. Inspect it carefully, make a decision. If it looks non-viable, strongly consider auto-transplanting it, moving it to a muscle pocket nearby to give it a chance to survive and function. Don't just leave it in hope.
Be proactive.
Be proactive. Also, if there's significant bleeding or a hematoma forming after surgery that could compromise the airway, the mantra is, treat it immediately, don't wait and watch. And finally, back to the cancer dissection point. Dissect only where disease lives, not by habit. Target the surgery, don't just do a routine dissection if it's not needed.
That makes a lot of sense. It's about discipline and facing reality, even when it's difficult. But tactically, during the surgery, how do they actually tell the difference between, say, a tiny lymph node and a crucial parathyroid gland? Everything must look so similar down there.
That's a critical intraoperative differentiation, and yes, it can be challenging, especially if there's scarring or inflammation. Surgeons rely on a combination of clues.
Like what? What are they looking for?
Color is a big one. Parathyroids typically have this characteristic tan yellow or light brown color, sometimes with a subtle vascular blush like a healthy peach. Lymph nodes are usually more gray-white or maybe brownish if reactive.
Okay, color is one clue.
Texture helps too. Parathyroids are generally soft, almost buttery, and quite friable. They can fall apart easily. Lymph nodes tend to be firmer, more rubbery, and often have a more defined, sometimes lobulated shape with a capsule.
Soft versus firm. What else?
Location, location, location. Parathyroids usually have fairly predictable locations. They tend to hug the posterior, the back surface of the thyroid gland. The inferior ones are often found near where the inferior thyroid artery crosses the recurrent nerve, sometimes down near the thymus gland extension. The superior ones are usually higher up, near where the RLN enters the larynx, often close to that Zuckerkandl tubercle we mentioned.
So knowing the typical geography helps.
Absolutely. And often you can spot a tiny, delicate feeding arteriole going into a structure that's a classic sign of parathyroid. Nodes don't usually have such a distinct, singular little vessel.
Are there any tech aids for this?
Yes, sometimes adjuncts are used if there's uncertainty. A surgeon might send a tiny piece for a frozen section biopsy, a rapid check under the microscope. Or they might do a PTH washout, stick a needle in, aspirate a tiny bit of fluid, and send it to the lab to measure parathyroid hormone levels. High PTH means it's a parathyroid.
Instant confirmation.
Pretty much. And newer technologies like near-infrared autofluorescence, NIRIF, or using ICG dye can help make parathyroids glow under a special camera, making them easier to spot.
Wow. Okay, so it's a combination of experience, visual cues, and sometimes technology. And this all comes back to that other aphorism you mentioned.
Right. Hypocalcemia is the surgeon's footprint, leave none. It's a powerful reminder that preserving those tiny parathyroid glands and their function is a direct reflection of surgical quality and care. Avoiding low calcium after surgery is a primary goal.
This really highlights the human element in surgery, doesn't it? That constant need for vigilance, critical thinking, not taking the easy way out. It's not just about technical skill with the tools.
No, it's absolutely not. It's also about judgment, experience, and a deep ethical commitment to anticipating and avoiding complications, ensuring the best possible recovery for the patient.
Okay, so that covers the standard challenges and the mental game. But beyond the routine, what happens when surgeons face really acute complications? Like, what if the trachea gets injured during the operation? Or what if the cancer has spread so much it's actually growing into nearby vital structures? These must be incredibly daunting scenarios.
They absolutely are. These are some of the most challenging situations a thyroid surgeon can face. Let's start with tracheostomy needing to create a surgical airway in the neck.
That's not routine in thyroid surgery.
No, definitely not routine. But there are specific serious indications. For instance, if a patient unfortunately suffers injury to both recurrent laryngeal nerves, causing the vocal cords to close off the airway, that's an emergency.
Bilateral nerve palsy.
Or if there's severe swelling or a large hematoma, a blood clot, compressing the airway after surgery. Sometimes, in cases of massive, long-standing goiters, the windpipe itself can become soft and floppy. That's tracheomalacia, and might collapse after the goiter is removed, needing support.
And cancer, too.
Yes, if there's invasive cancer directly threatening or obstructing the airway, a tracheostomy might be needed either temporarily or permanently.
So if it is needed, are there technical pearls for that, too?
Yes. Generally, the aim is to make the opening between the second and third tracheal rings, avoiding the first ring, which is close to the voice box. It can cause scarring issues, and avoiding going too low. Ensuring meticulous hemostasis, control of bleeding, is critical. Again, always being vigilant for that sneaky Thyroidea artery in the midline.
Always thinking several steps ahead, even about rare anatomy. Okay, what if the trachea itself is accidentally injured during the thyroid removal? How is that recognized and fixed?
Tracheal injury is a serious complication, thankfully uncommon, but immediate recognition is key. Surgeons look for telltale signs. Air bubbling up from the wound, maybe the anesthesiologist sees changes on the ventilator, or if saline is put in the wound, you might see air leak.
And repair.
Small, simple linear tears, maybe less than, say, 5 to 8 millimeters, can often be carefully repaired with fine, absorbable stitches like 40 PDS. You just suture the edges together carefully.
What about bigger injuries?
For larger defects, or if cartilage is lost, it might become much more complex, potentially requiring a segmental resection. That means removing the damaged segment of the trachea and then carefully rejoining the healthy ends. That's major reconstructive surgery.
Wow. Okay. And the really tough one. What if the cancer is super aggressive and has actually grown into the trachea or the esophagus, the swallowing tube behind it? Is surgery even possible then?
That's where things get really complex, and decisions are highly individualized based on the extent of invasion and the patient's overall health and fitness for a major operation.
So what are the general rules for resectability?
For tracheal infiltration, if the cancer seems to have only just touched or stuck to the outer surface, the adventitia, a surgeon might be able to perform a shave excision, basically just shaving the tumor off the tracheal surface.
But if it's deeper?
If it's clearly invading into the lining or the cartilage rings, then in carefully selected, fit patients, a window resection, removing a patch, or even a segmental resection and reanastomosis might be considered at specialized centers.
And the esophagus. Similar idea.
Similar concept, but perhaps even trickier. For esophageal infiltration, a shave excision is really only feasible if it's just stuck to the outermost muscle layer. Full-thickness invasion into the esophageal lining is a major challenge. Repair might involve complex flaps or potentially even a massive operation, like a laryngopharyngoesophagectomy removing the voice box, pharynx, and esophagus. But that's reserved for very highly selected patients, usually in the context of clinical trials or specialized centers.
So often, if it's that advanced, surgery might not be the best option.
For many patients with extensive tracheal or esophageal invasion, particularly if they aren't great surgical candidates, other therapies like radiation and systemic treatments often become the primary approach. The risks of major surgery have to be carefully weighed against the potential benefits.
What's truly fascinating here, listening to this, is the surgeon's incredible ability to adapt and respond to these immensely challenging, high-stakes situations. These aren't just procedures.
No, they're potentially life-saving interventions that demand immense skill, rapid judgment, and the ability to think creatively on your feet, always balancing that critical need to remove the disease with the equally critical need to preserve function and safety.
Absolutely. Okay, finally, let's explore a really fascinating point our sources brought up, the difference between a thyroid capsule and a prostate capsule. Why does that comparison matter so much in surgery? It sounds quite specific, but potentially very insightful.
It's a fantastic analogy, actually, because it perfectly highlights how the specific anatomy of an organ dictates surgical strategy, especially regarding its capsule.
Okay, refresh us on the thyroid capsule first.
So as we've discussed, the thyroid has its true capsule thin, stuck right on the gland, and the false capsule, the surrounding pretracheal fascia. The key surgical plane for thyroidectomy is right on that true capsule.
Why again?
Because working in that plane allows for that precise capsular ligation of tiny vessels, which is absolutely critical for preserving the parathyroid blood supply and protecting the recurrent laryngeal nerve right where it's most vulnerable near the gland.
Okay, so for the thyroid, dissecting on the true capsule is key to a safe functional surgery. How does the prostate compare?
Right. Now, the prostate, anatomically, it has a true histologic capsule, which is actually quite thin and insignificant surgically for benign disease. However, in benign prostatic hypoplasia, BPH, that common enlargement with age, the compressed normal prostate tissue forms what's called a surgical capsule or a pseudocapsule around the enlarged central part, the adenoma.
So a capsule formed by compression.
Exactly. And when a surgeon performs an enucleation procedure for BPH, like a HoLEP or simple prostatectomy, they exploit the plane between the overgrown adenoma and this surgical capsule to scoop out the benign tissue.
Ah, so they work inside that surgical capsule for BPH.
Correct. But contrast that with a radical prostatectomy for cancer. In that operation, the goal is to remove the entire prostate gland with margins. So the surgeon works outside the prostatic fascia, a completely different layer enclosing the prostate, specifically to preserve the crucial neurovascular bundles responsible for erections and continence, which run just outside this fascia.
Wow. Okay, so the term capsule means something entirely different anatomically and guides completely different surgical planes and decisions in each organ, all aiming for different goals: BPH relief versus cancer removal versus nerve preservation.
Precisely. It's a brilliant comparison. If we connect this to the bigger picture, thyroid surgery relies on meticulous true capsular dissection and ligation, primarily to preserve adjacent nerve and parathyroid function. Prostate surgery, on the other hand, relies on choosing the correct fascial plane either inside the surgical capsule for BPH function or outside the prostatic fascia for cancer control while preserving nerve function.
That's a powerful testament, isn't it, to how specialized and organ-specific surgical strategy has to be. Tiny anatomical distinctions dictate entirely different life-altering approaches.
Couldn't have said it better myself.
It really is incredible how those subtle differences in anatomy drive completely different strategies, but they're all aimed at achieving the best possible outcome for you, the patient. You realize it's never just a surgery, it's always custom-tailored.
Always.
Well, we have truly taken a deep dive today.
Wow.
From microscopic nerves and those anatomical triangles acting as the surgeon's GPS, to the intricate vascular superhighways, the critical evolution of techniques like capsular ligation. We've seen the meticulous decision-making that goes into everything from, routine thyroidectomies to really complex cancer interventions. We've learned just how much precision goes into what might seem like a fairly standard procedure from the outside.
And knowledge is most valuable when it's really understood and can be applied, right? Hopefully you, our listeners, now have a far richer understanding and maybe a deeper appreciation for the incredible level of detail and skill involved in thyroid surgery.
Yeah.
From managing that blood supply carefully to telling a tiny gray node from a tiny tan parathyroid to knowing exactly which plane to dissect in, every single detail plays such a crucial role in patient safety and ensuring good long-term well-being.
Absolutely. And thinking about that ostrich phenomenon in surgery, that crucial need for constant vigilance, to never bury your head in the sand, to always confront potential issues.
Yeah.
It makes you wonder, doesn't it? Where else in your own life, or maybe in other complex fields you know about, might that same philosophy, that refusal to ignore the difficult stuff, be just as vital to ensure the best possible outcome? Something to think about, isn't it?
Definitely something to mull over. Vigilance isn't just for surgeons.
True indeed.